members of our health community, okay, important people that are currently in charge of things that are on the grounds as it stands right now. And one of them is Dr. Ernest Bonsu. And I have the honor of introducing him to us. So Dr. Ernest Osei is a consultant clinical radiation oncologist and former head of oncology directorate at Komfo Teaching Hospital. His research focuses on cancer screening, early detection, multidisciplinary approaches, and cancer management. He holds a BSc Human Biology and an MBCHB, Bachelor of Medicine, Bachelor of Surgery, degrees from the Kwame Nkrumah University of Science and Technology School of Medical Sciences. He pursued a fellowship program at the University of Cape Town, Groote Schuur Hospital with College Medicine South Africa, where he obtained his FC Rad Onc in radiation oncology. Dr. Osei Bonsu has delivered numerous presentations at both national and international conferences in his field. He is passionate about mentoring young medical officers and supporting their professional growth. He is a fellow of the Ghana College of Physicians and a member of Ghana Medical Association, also a member of the American Society of Clinical Oncologists and the European Society of Medical Oncologists. He is an executive member of the City Cancer, a CCAN project in Kumasi. I have the honor of introducing to us Dr. Ernest Osei Bonsu. And if he's on the call, please, your audience, we are listening.
Thank you very much, Mercy, for the kind introduction. I'm struggling to upload my slides all this while. Can you hear me?
Yes, sir.
Hello?
Yes, Doc. Please, we can hear you.
Yes. Struggling to load my slides.
Good evening, Dr. Osei. So please, can you share your slide with me on WhatsApp so that I share it here as you present?
Okay. Let me see.
Hey, Stephen.
Yeah, okay. So, Stephen, I've shared my slides with you.
Please, I hope you can see my screen.
Yes, I can.
Yes, please. So I'll be continuing the slide as you present. Thank you very much.
Thank you, Stephen. Doc, please, you can carry on. Thank you.
Okay, so next slide. So that is going to be the presentation of the outline of my presentation. The reality. Okay, so he moves so quickly. So the first slide was my outline. Whether we like it or not, the burden of cancer is rising rapidly in Ghana. For the year 2022, about 27,000 new cases was diagnosed in Ghana. And in the same year, we recorded about 17,944 deaths. And that meant 49 deaths per day and 2 deaths for every 1 hour. I mean, the unfortunate thing is many patients present with advanced disease in Ghana. And if I should use breast as an example, then we have about 70% of our breast cancer patients always present with locally advanced disease or metastatic disease. In other words, cancer which has spread to other parts of the body. Many clinicians encounter unanswered questions daily. And that's going to be the subject of what we're going to talk about. Yet much of what we experience becomes or never becomes a research. Next slide, please. So what is cancer care? Basically, it is a multidisciplinary approach to preventing, diagnosing, treating, and supporting individuals affected by cancer to improve survival and quality of life. Now, know the key components: prevention and screening, diagnosis, treatment, supportive or palliative, and survivorship and follow-up, which we often forget. I mean, sometimes when you have treated a cancer patient and he's gone into remission, he doesn't have any evidence of the cancer in them, we just leave them. But even going back to settle in the society where cancer is a stigma, and the fact that maybe some late treatment effects are still being carried out by the patient is a reason why we should monitor their survivorship and support them. Now, basically, what is a research? It is a systemic and organized process of collecting, analyzing, and interpreting information to answer a question, interpreting results, or solve a problem. Next slide, please. And note the key features. It is systemic, it's objective, it's evidence-based, purpose-driven. So the layman will say finding answers to questions in a careful and scientific way. Now, in our everyday practice, we see patients, we do observation, and sometimes the observation that we do are different from what we read in the textbooks. So then what do? We ask ourselves, why is this so? Then we go ahead to gather, or we're supposed to go ahead and gather data to be the basis of evidence. Now, when we have that, then there's a need to meet stakeholders and then tell them, Jack, this is what we have found. So we think we need to do things differently. But having said that, at your corner, in the consulting room or in a hospital, you don't have the power. So you need the policy directive. You need the policymakers to shape the practice. Because in many institutions, when it is not coming from the top, you can't change how the people practice. And with a policy directive, bringing stakeholders together, we can always shape our practice, and that will lead to improved care. Now, in many settings, the process stops at the observation. Let me give one practical example. So about 4 years ago, we have some breast cancer patients who were being managed on hormonal treatment. Now we changed from one brand of the hormone to another. Then after 3 months, we were having a meeting, and I made an observation that after changing from one brand of medicine to other, I realized my patient has progressed, or the new lesion that had appeared on the chest wall of the patient. So I just mentioned it casually to the other doctors who were at the meeting. And then 3 of them also said the same thing, that they've also noticed changes in the response of the new drug, and that their patients have also progressed. And it also happened that it was around 3 to 4 months within the time that I observed my patients progressing. And it was the same change of drug from one brand to the other. So that is an observation. But ask me, what did we do next? We didn't do anything. We just reported it as adverse reaction to that of pharmacy, and we requested that they withdraw that particular drug from the system. But I think that shouldn't have ended there. We can come to that later. So research drive, there's something missing. Research drives better treatment guidelines. We use treatment guidelines adopted by, or treatment guidelines written by people having done, tests on different race of people and be tried on another race or ethnic groups. And sometimes some of the schedule of medication doses that are applied in other worlds, when tried here, we see things different. We make such observation. But if you ask me, what do you do about it? Not much. So local data could improve policy decisions. Evidence from Ghana can guide cancer care in Ghana and other African countries. Without research, clinical experience is lost. Next slide. Now, where do research questions come from in cancer care? For us, it could be from the patterns of late presentation. I'm just giving examples. It could be unexpected treatment responses. It could be toxicities or side effects in local populations. It could be barriers to treatment adherence, etc., etc. So one observation we have made at the Confanoche Oncology Directorate of the National Radiotherapy and Nuclear Medicine Department is many breast cancer patients present with metastatic disease. Recently, one of the doctors who presented his thesis for his fellowship worked on this thing, and it was found that 37% of breast cancer patients present for the first time with diseases which are spread to other organs or are metastatic. Now, research question could reflect a combination of patient, system, and tumor biology factors. So let's take a simple example of patient-level factors, and that could be health-seeking behavior. Now, questions that we can formulate as a research question could be something like, what is the median time from symptom to onset to first presentation among breast cancer patients? What sociocultural beliefs influence delayed presentation? Example, spiritual interpretation, stigma, fear of mastectomy. What proportion of patients initially seek care from alternative providers like traditional healers, pharmacies, faith-based centers? How do education level, income, and geographic location affect stage at presentation? All these are patient-related factors or factors at the level of patient that we can investigate. Now, we can also look at health system factors, as access and delays. And some of questions that we can formulate to find out answers to this late presentation could be something like, what is the time interval between first health care contact and definitive diagnosis? Are there delays in referral pathways from primary care to oncology centers? What is the availability of turnaround time for diagnostic services? Example, mammogram, biopsy, histopathology. Now, when we were in the medical school, it took 9 months for biopsy specimen that have been taken at Konfanochi Teaching Hospital to give you a report. So the turnaround time for biopsy was 9 months. And in 9 months, some patients are already gone. But that is it. Now the turnaround time is between 1 week to 3 weeks. So we've come a long way off. But elsewhere, you could have it in 3 to 4 days. Now, is it about the tumor biology and disease? So we can also look at that. It's not just that the patient delayed in coming. Maybe the tumor biology or the aggression of the tumor is said that the patient has not carried the disease for long, but is still present with metastatic disease because of the aggression. What are some of the questions that we can formulate to research? An example could be, what is the distribution of molecular subtypes? Example, triple negative breast cancer. Is it hormone responsive among patients presenting with metastatic disease? Or is there a higher prevalence of aggressive subtypes in your population? Or what is the tumor doubling time or proliferation index, something we call Ki-67? It gives you an idea about how aggressive the tumor is or how fast the tumor is growing. Now, all these are questions that we can formulate, address. We can come to screening and early detection gaps. So what proportion of patients have ever undergone breast cancer screening? What barriers exist to breast cancer screening uptake? Is there an organized or opportunistic screening program in the region? And how effective is it? Now, if you ask me now, for having worked at an oncology center for more than 25 years, I don't know the proportion of patients who have undergone breast cancer screening before they come there. I can give you just, I think all these are things that we need to have evidence for, so that if you want to argue out to the powers that be that we think we need to screen the patients, then you have the basis for saying so. We can look at questions from outcomes and survivor impacts, intervene-focused research, and then context-specific questions for Ghana. Now, all these are areas where we can formulate research questions to address late presentation of patients. So there are a lot that we are doing. There are a lot of data we sit on, but it stops there. Next slide, please. So what are the barriers in our clinical settings? So we keep complaining. There's heavy patient workload. When I was doing my fellowship in South Africa, we used to hold our breast clinics on Mondays. And we used to have a maximum of about 45 patients. That's on a heavy day. Surprisingly, for 5 doctors, 45 patients was a lot for us. So on every Monday, the hospital will have to engage 2 other locum doctors to see 45 patients from 8 o'clock to 5 p.m. in the evening. Now, at the oncology center here at Konfanochi, besides about 40 to 45 patients who are receiving radiotherapy who would normally not come to the consult room to be seen, except for those who have problems, sometimes we've booked about 135 patients, and that's for about 8 doctors. And for every patient who is on radiotherapy, every week they have to come and see the doctor. So for about the 45 who are on radiotherapy, maybe about 30% of them will also come and see the doctor. Okay. There's limited protected research time. Our workload is said that if somebody wants to collect data, sometimes it will be outside working hours. And there are a lot of issues, there are a lot of things that need to be put in place for people to do that. And when these are not forthcoming, there will be no motivation for people to do. There's a weak data system. Recently, for the whole of Ghana, it is only Kumasi that used to have population-based cancer registry. Now, come the electronic medical record system in 2018 that we used to call the LIMS. Everything was migrated to the electronic system. And then there was difficulty in extracting data. So from 2018 latter part to now, the data that was being collected for the cancer registry stalled. We've not been able to do it. Much as we try to see the programmers and the hospital IT group to help us, fine tune so that we can extract the data, it became difficult because Confanachi sees about 800 to 1,200 new cases per day. Now, with the new system, when the data collectors were trying to collect, now suddenly 1 month, there were 2,500 new cases. So we realized the system was wrong. So it has been stalled. There's limited funding for clinical research. These days, it's even better. Every year, I use Confanochi as an example. There will be an information that doctors, nurses, everybody working in the hospital, pharmacists, laboratory scientists, everybody who have research that they want to do, they should send a proposal to be funded by a central administration. And there's lack of motivation. We sit on data, So how can we strengthen the foundation? The foundation is data. I had opportunity to attend in December last year, the National Cancer Forum. And then there was mention of the Mahama Care coming to treat all cancers on the insurance or the new program. So I told them, the LIMS or the electronic record medical system that we're using has been cancelled by the ministry. There's a new one which is being put in place. Can we quickly, for stakeholders, sit down? Can we sit down, stakeholders, programmers, to look at the variables that need to be put into the system so that at a click of a button, we can export data into the registry? Now, this system says it's going to take care of all cancer patients, but I tell you what, with the old system, only breast cancer patients and cervical cancer patients were being taken care of under the insurance. Even with that one, there was disagreement on some of the services to be provided for the cancer patient because the tariffs being offered by the government was way below what the institutions wanted. For instance, at the time, the government wanted to offer 250 Ghana cedis for CT scan of the chest, while the institution wanted between 450 Ghana cedis and 500 Ghana cedis. So because of that, the institution said, we're not offering any CT under the insurance. So patients were having to pay out of pocket. So I told them, before we start, let us look at the numbers. If somebody came to you and said, please help me to pay the school fees of my kids, you just don't say yes. The first thing you ask, how many are them? At what level of the education are they? Now, if he start to tell you 5 are at Legon, 2 at K University, 3 are senior high school and stuff, then you know you don't want to bite more than you can chew. So, last slide, please. The previous slide, please. No. Yes. So, functional cancer registries. If you don't have the numbers, you cannot do any effective planning. Now, the electronic medical system, record system, has said that if you don't input all the variables that you need for cancer registry, then it will be very difficult to actually pick numbers from the system for any meaningful planning. And then there should be standardized clinical documentation. I mean, clerking sometimes by doctors leave a lot of information just because sometimes of the kind of system they are using. There's always an easier way to, for instance, clerk a patient onto the electronic medical system. But then if you want proper data regarding cancer patient, then doctors must also stick to protocol. And then you should have dedicated data managers. When you had a working visit to the Mayo Clinic in the US, they have data management of their cancer data. And it's so nice. You go there, and for any information that you have, at a click of a button, they can get you. And then when you're doing a research, they help you with the type of information you need. This is something we are lacking here. So what we need to do, we need prospectively to get good clinical databases. There should be departmental research meetings to actually come out with a type of information that we need for some of these researches we are talking about, so that can be embedded into whatever electronic medical system records we have. There should be a clinical audit to find out outcomes of treatment that we give to our patients, so that we can also compare how our patients respond to treatment given out here, or treatment that is enshrined in some protocols or guidelines that we use. Now, if you do that, you're able to compare your practice, whether you are doing the right thing or what you're doing here is comparable to elsewhere. Next slide, please. So we need to build a clinician scientist. During our training, I think there should be a conscious effort to train people or to orient people on how to collect data, how to make observation, how to structure or come out with research questions. I mean, that should be something that should be embedded in training residents. Of course, they should be mentored. And one of the things is, if somebody is doing his or her residency, and then you're a consultant or senior specialist, and you ask him or her to do something with the data collection for a paper to be written, and he or she sees her name, as part of the group that published a paper, it's a kind of motivation. So even as soon as they come out, I mean, they feel like, also working hard to publish. Because in many institutions, you say you publish or you perish. So when they are in the training institution, or somebody is a specialist or senior specialist, and a senior person kind of brings him or her under his tutorship, it is very motivating. There should be multidisciplinary collaboration. Now, all of us are aware that cancer, nobody can sit in his or her corner and then start managing cases. No. Everybody who is part of the management of the cancer at any point in time should be part of the initial decision on how to manage. I think it makes initiation of treatment faster, and then when there's a problem, 2 heads are always better than 1. It is also important that we partner the universities, research institutions, and then the pharmaceuticals. Now, what will be the impact of bridging this gap? If you're able to bridge this gap, there'll be evidence-based cancer care. Now, sometimes when I attend international meetings, typically there's a collaboration between Confanachi Teaching Hospital and the Michigan Gynae Oncology Group. Now, there's a condition we call cholangiocarcinoma. Depending on the stratification of the patient, they have to be treated with a single agent, double agent, or whatever. Now, with some of the management, you need to be doing frequent laboratory tests to determine the level of certain or the drug that you are using. And it is very difficult, even in the developed country, to do that. So we have combined some of the drugs in the first line and the second drug in the second line, and you're using it to treat. It means that when patients relapse, then you don't have many options. But I tell you what, we are getting a very, very, very good outcome. And to the best of my knowledge, many of the patients who have been treated with that protocol have never relapsed, and many of them have stopped coming for follow-up. So whenever these collaborators come around, they say, "Oh, let's look at the data and write. Let's look at data and write." You haven't written, and once you haven't written, once you leave the department, it is gone. So we have to, the evidence-based cancer care could bridge the gap, improve patient outcome, can motivate us to, bridge the gap, stronger national cancer policies. Now, in spite of all the things that we are saying, I think most of you can attest that you've done researches, come out with findings, have been presented to some authorities, but as we sit, you're just sitting on some shelf gathering dust. Everything has been explained to them. We need a policy direction. Because once it hasn't come, you cannot on your own start to implement. So that is some of the challenges we are having. Next slide, please. So the key message is every patient we encounter is a potential research question. The future of Ghana or the future of cancer care in Ghana depends on converting clinical experience into evidence through research, bringing stakeholders and policymakers together to drive the changes that would improve care of the cancer patient. Thank you for your attention.
Thank you very much, Dr. Ernest Osei Bonsu. We are very grateful for making the time to present on this particular topic. I'll let Fortune handle the questions and answers. Fortune, please, over to you.
Okay, thank you so much, Orwell, and thank you so much, Dr. Osei Bonsu. Like you said, every patient encounter is a potential research question. And I hope that all of us on this call, this platform, takes that home with us, in our daily encounters with our patients. Just quickly, think what is a problem over here? What problem have I identified over here? And is there a research question? And I'm sure most of the time we would find one. So it's now time for a question and answer session. And yes, so the floor is open for questions. If you have any questions, you just raise your hand and then we will call on you to ask your question.
Okay, so Fortune, my question is, Doc, please, when you were talking about the cancer registry, I know that the Globacon 2022 estimate for Ghana was able to be done because of the cancer registry that we have, the Kumasi Cancer Registry, that's the CCAN initiative. So please, right now that the LIM system or right now even schemes has taken over, how are we going to get that data to actually even get a general estimate to assess, let's say, the incidence of particular kind of cancers that we have because of the challenges that we are having with the games and the LIMS and all those new management systems? Thank you.
Okay, very important question. So up to the last quarter of 2018, data was extracted from patient folders. Now, come last quarter of 2018 to now, we migrated to the LIMS. So the question was, how could the data collectors go on to collect information to update the cancer registry? They had challenges. I think they had limited access to certain information. And the information that they needed had been said that not all set variables have been put on the LIMS. So sometimes they needed to read doctors' notes to extract other information. And that was very difficult because the access were limited to the a portion or some aspect of the LIMS. And that is how come for one particular month, they said they have found 2,500 new cases, when over the years, it's been 800 to 1,200 new cases. So somebody starts somewhere and says he's been canceled out the LIMS. Now, hospital didn't have any backup. It was just a week ago that the medical director told me they've been able to have some software to be able to assess the old system. So with that, we could go back, if the human resource base is strong, to collect data and then update the registry. Now, with the new games that has come on board, that's why I was suggesting that right from the word go, clinicians, other stakeholders the developers of the program must sit down and we tell them, this is the variable that we need. Are they all captured under the new program? Are they all captured under the new software? Now, if they are, updating the cancer registry will be very, very simple. Now, we were thinking that as we speak, there are many institutions that have institutional data or hospital-based data or cancer registry. And then invariably, you find out that there are some variables which we're missing. And that is why I want to see those programmers this time around, sit down with them right from the word go, so that they input those things. So at the click of a button, the information that we need for the registry can be exported in the cancer registry. So we're still talking about them. When we had the last year National Cancer Forum, they said we were going to meet again in July this year to consider that. And the concern some of us raised is, do we have to wait for 6 months or after 6 months when certain data has been put up before we come to, correct and put in, the variables? So does it mean that for the first 7 months, if you want to collect information on those patients, it's going to be some, trying to go through because something might have been left out? But this is where we find ourselves. Sometimes the policymakers don't understand people who are down there working. And that is a big challenge. Thank you. I hope I have answered your question.
Yes, please, Doc, you've answered. Please, just a follow-up. So please, with the registry, right now we have CCAN, which is functionals. I think way back in 2012 or something, we have a proposal to also have Accra Cancer Registry. I'm looking at the liaison. How do we link up with, especially research being done in Kolebu, or let's say cancer can be done in Kolebu, data being collected? How do you get all of those together to kind of present a picture? And the last one, just to double down, the data that is collected, please, do researchers or students have access to them? For example, if they want to study trends for example, for bioinformatics studies or anything, do we have access to this kind of data to be able to use them and for research work? Thank you.
Okay. The truth is, even in the so-called developed countries, they don't have one cancer registry. I mean, you may have 5 or so areas where National Cancer Registry is. So at any point, they can aggregate. So Kolebu has a hospital-based cancer registry. Kumasi used to have, or we have, hospital-based cancer registry, in addition to the population-based cancer registry. That is not owned by us. It's owned by the Metro. So we were thinking we could have one registry in Kumasi, one in Accra, one in Tamale, and maybe Cape Coast and Ho. We're thinking so that if we are all using the same method to extract the data, then it's a matter of aggregating to get a national registry data. As simple as that. I mean, when you go to all or many countries, they have a couple of cancer registries and they aggregate, and they are also able to export into a national data center for them to aggregate. Now, for every cancer registry, if you want to access data, I think there's a way you have to access the data. It has been a challenge. You are there at the oncology directorate. You are not the only person that contributes to the data. But many of the patients, when they are diagnosed, they are brought to the directorate to be treated. So they stay with us for long. So, and then I think the record keeping at oncology is quite loadable. So at any point in time, people come there, they want the data. And some of them are using to attend conferences. And there are times that the interpretation even they give to the data is not what it is. So it becomes a kind of tug of war. I mean, somebody some time ago was in charge of the data, we didn't even want to give it out. But that is not right. If somebody is working in surgery and he or she diagnoses a breast cancer in a patient and he does surgery and send the patient to you to be given chemo treatment, radiation, and the sort, the patient is for the hospital, for all of you. If the person, anybody needs information to the, information from the registry, it should be given to them. But for every hospital, there's a written policy as to how people can ask for the information. You write and then the information is given to you. But the information is not for you, the person working at the oncology directorate alone. It's for the hospital. And there are guidelines as to how you can access. So if you ask me, say, is there access to data? I'll say yes. Thank you.
Thank you. Thank you very much, Doc.
Thank you very much. This is just a reminder, please, you can send your questions to the chat box, okay? We would read them. Also, if you want, you can raise your hand and we'll call on you to unmute and ask your question. So this is a question from Ernest Samoa. It says, residency and fellowship are demanding clinically. How can a junior doctor realistically balance those intense clinical hours with the dedication or the dedicated time required for meaningful research training during residency and fellowship?
Yes, it is true. But even working as a resident, you could make an observation that could help you to formulate a research question. And then you look at it. Look, residency is not something, I'm not going to say it's difficult, but all it's about is you are being trained to be, or to a point that you say you are safe to practice. Okay. You are being trained. I mean, the same patient you see every day that we discuss is the same kind of patients you see during the exams, the same type of relevant questions we ask you during the training year that we ask you. We just want to see that you are safe to practice. So if you are a resident, often you wouldn't bother yourself like taking upon yourself a research question and doing it yourself. But you may have your consultant working on a topic, and sometimes you are brought into the discussion, or maybe to collate certain aspect of the data. You not be overburdened with that, so that you get a sense of how it is done. And there are many institutions where people are resident. By the time they finish, I mean, they've written papers, or I mean, they are part of a paper which has been written by their consultants because they contributed in one way or the other. So I don't think it's about you, the resident, like you haven't even finished your membership and you are tied down with a research question trying to come up with data. I mean, you get yourself into some aspect of the research that maybe your senior specialist or consultant will be doing. But then what we are saying is they must grow the culture of knowing how to come by the research question, how to make critical observation about patients, and then as they become fellows or they are on their own, they make any observation and they know how to proceed. Thank you.
All right, thank you very much. I have a question about our readiness for clinical trials. I had a colleague from another country, maybe a senior colleague, mentioned to me that he was trying to collaborate with one hospital to conduct some kind of clinical trial for cancer patients or neuro-oncological patients. And he didn't see that readiness or that preparation from this institution. And I'm just wondering if you could throw some light about how prepared we are as maybe Konfanoche is, or maybe Kolebu is, or as a country to handle these collaborations that may come in the future, or these doors of opportunity that are here right now to put our patients on some clinical trials that can help them, with their disease or
Okay,
alleviate the
that's a
burden of the
very,
disease. Yeah,
a
thank
very,
you.
very interesting and important question. Every now and then, our doors are open for research. Whether you are doing it in Ghana or the originator is from Ghana or elsewhere, your study design or you apply to do the research, that's the first place. And then all the thing that you must put in place should be, and you should get ethical clearance from the hospital. Now, if it involves the export of, let's say, samples or human tissues, They all have agreements and protocols that need to be fulfilled. So there's no way anybody puts impediments in the way of any research unless, some conditions about the research are not satisfied by the standard of the hospital. Sometimes, excuse me to say, some of the researchers practicing outside the country think that in Africa, because of poverty and stuff like that, you can just go about doing research anyhow. For instance, if you want to do a research and it will require taking human sample like blood or tissues, even elsewhere, where let's say a breast cancer surgery is to be performed, the whole breast is to be removed. Now, before it is done, the patient might have been diagnosed as having a cancer. But then the initial diagnosis was just by using a special method called TrueCut, taking a small biopsy. Now, if they want to get a bigger tissue, the breast has been taken out. There's so much tissue that you can work on. Now, if you want to put some of set tissue in the tissue bank, you need to get consent from the patient that, look, we have your diagnosis, but would you agree that during the surgery, when the breast is taken out, the tissue that we're going to throw away, would you agree that we take part of it and store so that in the future, if there's a need to try a new drug, we can try it on it, and perchance, if something come out, you'll be one of the people who could benefit from the new drug. You need to take permission. Now, when some of these researchers come to Africa, they do things in such a way that the standard that they want to carry out such studies under doesn't conform to what they do in Europe. Otherwise, if it conforms to the standard that is what the hospital required, nobody has any problem. So I don't know exactly what problems was encountered. And for some of these researchers too, they need certain laboratory equipments and they need other certain things. So sometimes some of these are lacking and some of them are not ready to maybe provide funding for those things. And they think maybe the hospital should provide it. And, we are always complaining that we don't have money. So if they say like that, it appears the hospital is not even interested. No, it's not like that. But some of the equipments are heavy because there's one that we wanted to do. We need a minus 25 degrees Celsius fridge. And we needed a big one. We wanted to keep tissues for over a certain number of years. And then if anybody wanted to do a research on breast cancer, for instance, that was for breast cancer. Then we see all the agreement, whether it satisfies the international standard, and then they go to ethical clearance, and then we can go ahead. So nobody impedes anyone who want to carry out the research, who are the standard, the study design, everything is in place. Unless there's something outstanding that borders on funding and that is not readily answered, then it can't be carried out. So maybe, I don't know the details, but there could be something. Yeah.
Yes. All right. Thank you very much. Thank you. So please, we have one hand raised. Erica Labi, please, you can ask your question.
Thank you so much for this opportunity. Please, I wanted to ask, based on the funding, is this my question? Based on the funding, does the government actually have allocations for cancer research? Because there seems to be little improvement in the area, even though it's a major place to look at in the health field.
The voice is very faint. Hello? You sounding far away. You are sounding far away.
Hello.
Yes, it's better now. Please go ahead.
Please, I wanted to ask, this is my first question. I wanted to ask, based on the funding, do we have funds allocated to the cancer research area? Because it seems that there's little to no improvement in that area, even though it's a major area of concern in the health field. Because I'm very intrigued by that, and it seems there's nothing going on there.
Okay, quick answer. In the hospital, they say you can't spend what you haven't budgeted for. So if the oncology directorate or anybody in the oncology department who wants to carry out a certain research, now he puts a budget in. Like this year, you put it in against next year because the budgets are sometimes budgeted 5 yearly or yearly or something. And then whatever expenditure you want to carry or you expect to incur, your department should be also generating money. And if your department is not generating money and you are asking for money to be used for a research, the question is where is the money to come from?
Yes.
So oncology directorate, somebody in the department wants to carry out a research on breast cancer next year to the tune of 100,000, then you put that budget into the program of action. And then there's always other things done in the department that generate money. So the budget is submitted to central management. Now, once the board approves the budget, it means that your proposal to carry out a research has been approved. So the following year, you can write to assess the money. But if the budget is not approved, then you cannot ask for the money for the research. So that is how it works out. Now, these days, the hospital has opened up a channel saying that they want good proposal for researchers. So research proposals go from the various directories, and the research team or a committee will look at it and pick a couple of them, and the hospital sponsor decide what the directorate will submit as part of what they want to do the following year. There's an avenue for interesting researches to be carried out in the hospital that people can apply for. I mean, like you send your research, the team will look at it, and when it's interesting, they will sponsor you to do it. So that is how it is working now at Confanoche.
Thank
Yes,
you.
please,
Erica,
please. I
please.
wanted to ask. Oh, sorry.
No, I was just going to ask if you had any other question. Go
Yes,
ahead.
please, I do. Please, I wanted to ask about the data system again. Can you propose to the hospital that yes, I want to be taking data samples myself and then go around like take a full day, a full time off, and then be going around. Let's say we choose an area such as maybe Accra, for example, and then you take the data samples and then share it to your colleagues. And is it beneficial? As in, would it be that it's going to be become a general data sample for everybody so that it can benefit other hospitals, even though maybe no one is making that initiative?
Okay, if you submit a budget proposal to the Institutional Review Board, IRB, they will look at it, what you want to study, how you want to go about it, whether it is ethical, what are the timelines, what are your budget constraints. They look at all that and approve the budget for you. Now, if it is about data collection, you are working in a directorate and you take a day off to go and collect data. That one is an arrangement between you and your directorate. Of course, you wouldn't expect that for 2 months you are away somewhere collecting data and you are being paid. So these are arrangements that you could make because people are working, they still collect data. 1 or 2 days to travel somewhere to take data, I don't think is a big deal. But if somebody will have to stay away for, let's say, a month, being elsewhere collecting data, it is different from where maybe a hospital has constituted a team that is carrying out a research. That one, you have the liberty to do wherever. But wherever you go, you need to inform the hospital that this is what you are doing. So even though the outcome of your research will be a benefit to the hospital and to change practices for good outcome of having treated your patients, it has to conform to certain norms. Thank you.
Doc, please, I want to ask that do you want us to also start our own cancer research institute?
That would be a good idea. That would be a good idea so that starting your own cancer institute means that you have many of the things that are required. It's not just an office. There are many of the things that are required for, let's say, if you want to research into one of the cancers, let's say, I've always used the breast cancer because it's very common. You need a good laboratory, to support many of the tests that you do. You need good tissue samples. If you really want to talk about your patient properly, you need to have good staging investigation. By that, I mean that when the patient has reported in the hospital for cancer and it's been confirmed, you need to establish the extent of the disease in the person by way of imaging. So all these things come in. You may not necessarily have it in one center. That's why I was talking about the multidisciplinary approach, because you could have a laboratory, or yes, a laboratory that could work on the tissue samples and the blood samples. You could have a radiology or imaging section that is working on. So it's just a matter of coordination. You don't necessarily need to set out a center. That is, if you have the resource, that is fine. But even if you set it up, you need this human resource base. The pathologists, the radiologists, the surgeon, the oncologist, the nurse, the palliative care nurse, and the general nurse. And even when you talk about multidisciplinary patient or multidisciplinary management of the patient, you even need the psychologist and sometimes the chaplain. So it's a matter of not necessarily convenient at one point, but these days you can even do it virtually, as we're trying to do now. So you could be in a hospital where you have a radiologist, you have a surgeon, but you don't have a pathologist. Now, you could take a shot of your slices after you've taken the biopsy and send it to a center where the pathologist can even look at it and report for you. So at a meeting, that can be done virtual. It's like you have the whole team of the multidisciplinary, members, everybody being there. But in your hospital, maybe you have only 2 of them. So we are using technology to make up for some of the things that we don't have at certain centers. And together, we'll come out with the same ideas as if we are all sitting together and managing the patient. So sometimes it's about coordination. Sometimes it is making up the deficit you have through virtual meeting with other people who have the resource. And at the end of the day, the outcome of whatever decision is the same. So making use of technology is also one of the ways to go. Thank you.
All right, thank you very much. And thank you, Erica, for your questions.
Thank you too for
Just
the
like-
opportunity.
Yes, please. So for the first session, it's been very informative, and I'm sure we've all learned a lot. But it's now time to move on to the next speaker. And before I do that, I just want to say a big thank you to Dr. Osei Bonsu for his time and for taking us for this session. So, Owa, you can go ahead now to introduce the next speaker. Thank you.
Thank you very much, Fortune, and thank you, Dr. Osei Bonsu, for making the time to speak to us. So please, I will
Thank you.
introduce the next speaker.